Hello, my name is Olivia Kading, and I'm going to be talking about ovarian cancer. The purpose of this presentation is to discuss the incidence, causes, and management of ovarian cancer, as well as current and future treatments of the disease and its relation to palliative care. Ovarian cancer occurs in the ovaries, which are the reproductive organs in women. The ovaries are responsible for the production of eggs and hormones, specifically estrogen and progesterone. The ovary is made up of 3 cells: epithelial, germ, and stromal. Each of these can become cancerous. However, epithelial cells are responsible for 90% of ovarian carcinomas, and much research has been done on this type. The American Cancer Society estimates that in 2021, there will be 21,410 new diagnoses of ovarian cancer and 13,770 deaths. Ovarian cancer is currently the deadliest gynecological cancer, and I will be discussing why that is. Ovarian cancer affects white women more than African American women, and about 50% of women are diagnosed at the age of 63 or older. Ovarian cancer begins when changes occur at the molecular level. This includes changes in the cell's microenvironment, which are caused by genetics and epigenetics. And epigenetic changes alter gene expression, which lead to different tumor markers. In a review about the epidemiology of ovarian cancer, risks and preventions are discussed. A major risk factor for developing ovarian cancer is a family history, specifically those with the BRCA gene mutation. 36% of ovarian cancers occur due to genetics. Hormones and reproductive factors have also been studied and linked to ovarian cancer. One of the main causes of this is the incessant ovulation hypothesis, which states the more cycles a woman has, the higher risk of mutations. This will be covered on the following slide. Lifestyle and environmental factors such as obesity, nutrition, physical activity, smoking, alcohol consumption, and asbestos may play a role in the risks of ovarian cancer. However, there is not enough data to prove these as specific causes. Research regarding the incessant ovulation hypothesis has evaluated multiple risks, including the age of the first period and onset of menopause. As girls are getting periods earlier in life, this has become a concern. However, there is small evidence to link this as a cause. Pregnancy and infertility studies have found that women with no pregnancy have higher risk of developing ovarian cancer than those with temporary periods of infertility. Lactation is considered a preventative, as this leads to anovulation or no ovulation. Benign gynecological conditions such as PCOS and endometriosis were found to have a possible link, but more research needs to be done. Oral contraceptives have been studied, and there is consistent data stating that they are preventative in the development of ovarian cancer. Hormone replacement therapies do not fall in the incessant ovulation hypothesis, but continue to be studied and are considered a moderate risk. Estrogen is thought to encourage the replication of ovarian epithelial cells, which would assist in cancer proliferation. Symptoms of ovarian cancer are problematic. Many patients are asymptomatic early on, and symptoms present after the disease has progressed. 60% of women are diagnosed after metastasis has occurred. This cancer commonly spreads to the peritoneum and omentum, leading to symptoms. These symptoms are nonspecific and often not recognized as cancer and may not be concerning to those experiencing them. These symptoms include back pain, fatigue, abdominal pain and bloating, constipation, and urinary problems. If someone is at risk or suspected to have ovarian cancer, a family and lifestyle history should be obtained. A physical examination should include a rectovaginal examination with an empty bladder to evaluate for tumors in the abdomen and pelvis. This exam does have limited accuracy, especially in those with obesity, and should not be the only screening or test performed. If a mass is found upon examination or symptoms are of a concern, a transvaginal ultrasound should be performed to assess the anatomy of the ovaries and detect for masses or ascites. Blood tests should also be done, including a CBC, liver function, and serum biomarkers. CA125 is a common serum biomarker tested. However, it's not specific enough, as it's elevated in 80% of those with advanced disease, but only 50% with early stages. This is an indicator that research needs to be done to find more specific screening for ovarian cancer. In a study by Dubani and his colleagues, they suggest a referral to a gynecological oncologist if CA-125 is greater than 200 in premenopausal women, if there's any elevation in postmenopausal women, a pelvic mass is detected, metastatic disease has occurred, or there is ascites with unknown cause. The primary treatment for ovarian cancer is surgery to debulk the tumor and stage the cancer. Surgery is potentially curative if the cancer is contained to the ovaries. This occurs in very early stages. Chemotherapy is typically performed in those with any advance in disease. This may be intravenously or intraperitoneally. Research shows the combination of IP and IV increased survival rates by 12 months compared to only IV chemo. It is suggested that these women follow with a gynecological oncologist for 5 years following treatment, as recurrent rates are 25% in early stages and 75 to 80% in advanced. Surveillance recommendations are on the table on the right. If recurrence is suspected, a CT and PET scan should be performed. Palliative care should be offered to patients upon diagnosis, especially those with advanced disease, as metastasis has already occurred and the prognosis is poor. Many of the things already discussed in this presentation indicate why palliative care is important for patients with ovarian cancer. It is the deadliest gynecological cancer. Symptoms are vague, and once they occur, the disease has progressed. There is lack of specific screening, and there are high rates of recurrence, as well as chemoresistance occurring, which leads up to 4 or more lines of chemo. There's been no improvement in mortality rates for 40 years, and there is heavy symptom burden from progression of disease and treatments. Research indicates that patients with palliative care early on have improved quality of life compared to those with standard care. In a retrospective analysis, it was found that more than 70% of women had 3 lines of chemo or more, and many never stopped. 81% needed supportive therapies, including paracentesis, TPN, and transfusions at the end of life. This topic was inspired by 2 patients that I cared for as an aide and a nurse on an oncology floor. These 2 women were in their 60s, and I knew them well because they were what we call frequent flyers. As their ovarian cancer progressed, their admissions increased, and so did the length of their admissions. They both had frequent nausea and vomiting. I remember constantly giving IV pushes of Zofran, Compazine, and even Ativan. Many admissions resulted in NG tube placement for decompression. I remember I called the doctor to let them know the patient needed fluids because she had so much NG output. The abdominal pain from the cancer itself and the distension of ascites resulted in the need for paracentesis. Ultimately, both of them were spending the rest of their life lying in a hospital bed. Although it took multiple attempts to get palliative and hospice on board, both of them did pass peacefully at home with their families. 2 articles that provide evidence regarding current treatments for ovarian cancer were Ovarian Cancer, a Current Status and Strategies for Improving Outcomes. This study is a systematic review discussing the treatments and recommendations for future research. And Diagnosis and Treatment of Ovarian Cancer. This article discusses the combination treatment approach and recommendations based on the staging of the cancer. In the first study, they discussed debulking surgery as the primary treatment to remove the tumor and cancerous cells. Chemotherapy would be important for the treatment of ovarian cancer, and chemo can be given IV, IP, or in combination. The current recommendations support the administration of platinum and taxane drugs, commonly carboplatin and paclitaxel. Immunotherapy currently has low rates of success and has not been FDA approved, although with future research this may be promising. The future research of biomarkers will create more specific screening for earlier detection, and understanding these biomarkers will assist in the understanding of drug resistance and future treatment options. The conclusions of this study found that IP chemo was the most effective in peritoneal metastasis. and cytoreduction followed by chemo was the most ideal treatment for a cure. The second study recommends the evaluation by a gynecological oncologist for cytoreductive surgery. If surgery is considered high risk or with larger masses, which are greater than 1 centimeter, neoadjuvant chemo should be completed, which is chemo before the surgery. If disease is advancing with chemo prior to surgery, options include offering another line of chemo, clinical trials, and/or palliative care consult. In this case, surgery is not recommended, as the cancer has already progressed. Staging is important for resection and knowing the need for additional chemo. This study also supports the use of platinum and taxane combinations for improved survival. In treatment of advanced disease, the suggestion of surgery in combination with IV, IP, and/or anti-angiogenic therapies. The current support offers IP over IV. And they found there is no clear data to support the use of maintenance therapies after primary treatment, and research is still being done. My references are on this slide. Thank you.